This is Willie Kemp. This is Disorders of White Blood Cells Part 3. There'll be 6 parts. There are the websites for me and Dr. Hughes' questions, and then my Twitter, which I haven't been active in for a while, but I'm going to start again. And as I said, I'm a forensic pathologist, but I have a very strong interest in general pathology, organ pathology, and just in teaching medical students. Here are my disclaimers. Read these. If you do not agree, do not watch the video. Disclaimer number 3, same thing. And then just in case you want to understand my teaching methods and that, I create an introductory presentation that describes it. Here are my references. A lot of these I wish I had had when I was in medical school. Sometimes forming that differential diagnosis and understanding how that goes. Seems like medical school teaches you from the backwards, the disease, and tells you the symptoms, but patient comes in with symptoms, you got to determine the disease. And I just wanted to thank the University of North Dakota's Department of Medical Laboratory Science. They have a fantastic collection of hematopathology, blood, and bone marrow smears, and I was able to photograph those. And without that, I wouldn't be able to do this as a forensic pathologist, because we do not see that good of hematopathology. It's usually autolyzed. So there'll be 3 questions at the beginning, so just pause, see if you can answer the question, and then move on. The idea is that it helps you as you're going through the lecture to retain information. It's been shown to do that. So, second question, pause, and then we'll go through these at the end. And then third question, pause, we'll go through it at the end. So, continuing on with the specific types of non-Hodgkin's lymphoma, we'll talk about follicular lymphoma. This is germinal center B cell. A lot of the lymphomas, it seems like, have that as a cell of origin. Very common. It's 40% of adult lymphomas, mostly just in adults. And then as with other lymphomas, they'll present with a painless lymphadenopathy. This one has a translocation 1418 and puts the BCL2 gene next to the immunoglobulin heavy chain. So remember, I said chromosome 14, that's that immunoglobulin heavy chain gene locus. And so that is transcribed all the time. And so if you put a gene next to it that shouldn't be transcribed, it gets transcribed. And then that's what happens. So with BCL2, it's going to inhibit apoptosis, remember. And then so basically the cells are immortal. And then there's also a mutation that can involve the MLL2 gene. What you see is an effacing of the lymph nodes, which means the nodal architecture is wiped out. You don't see the nodal architecture. And it's nodules, the follicles. They can be composed of both central sites, which are small cells, and central blasts, which are larger cells. You see minimal mitoses, because remember, these cells are immortal. They're not dividing, which is, I believe, why they can be difficult to treat, because the cells aren't dividing. And so in the past, standard chemotherapy has targeted dividing cells. Nowadays, they're coming up with, it seems like, more medications that can treat a variety of mutations and different things like that. But anyway, so there's no apoptosis because BCL2 is elevated, inhibiting it, and there's no tingible body macrophages. So these are kind of a sign of activity. So you would see tingible body macrophages in follicular hyperplasia, but you're not going to see them in a follicular lymphoma. It's a B cell. So you see CD20, you see CD10. Remember, we talked about that with maturity. It seems like CD10 comes in relatively early in maturity, but really, really early pre-B cell neoplasms and ALL don't have it. And then BCL6. And then obviously going to be BCL2 positive also, because that's the translocation. So these are follicular lymphomas. So just so you know, my diagnoses have always been made by asking somebody or showing somebody or things like that, because I'm not a hematopathologist. So my diagnoses have always come from study sets, from cases I've had where I've been able to show pathologists, or from study sets that I have access to photograph. So based on nodal architecture, so you basically don't see any normal lymph node in there. I put the translocation up there and the important parts of it just to kind of integrate the picture, the diagnosis, and the translocation. Because knowing these translocations is very important. And these translocations were known when I was in medical school, so quite some time ago. Okay, so about 30 or 40% progress to diffuse large B-cell lymphoma, which is a much more aggressive lymphoma. And then they have a long survival period, but they're not curable. And I'll show you a good slide of this where we talk about mantle cell. or at least they weren't curable. I never know with some of the things they're making and stuff like that. Maybe sometime, but it's usually because in the past they're targeting the dividing cells, and there's no dividing cells. They're immortal cells. So here's once again the follicular hyperplasia versus follicular lymphoma. Very important differential. The nodal architecture in follicular hyperplasia is preserved. I mean, it's a reactive lymph node, but it still looks like a lymph node. Whereas follicular lymphoma, the neoplastic follicles basically wipe out the normal architecture. There's variation in the size of the germinal centers in follicular hyperplasia, whereas they're more consistent in follicular lymphoma. And you'll say, well, that last image, they didn't all look the same size. No, but they're just more consistent in size. The size and shape of the germinal center lymphocytes varies, more consistent in follicular lymphoma, because remember, it's coming from one clone. And then with the follicular hyperplasia, you would expect to see mitotic and phagocytic activity in that germinal center, those tingible body macrophages, where you do not see that in follicular lymphoma. So mantle cell lymphoma, this is from naive B cells. This is also an adult type tumor. Clinical features, fatigue and lymphadenopathy because it's a non-Hodgkin lymphoma. And it doesn't have to be contiguous. Hodgkin's is contiguous, nodal groups, but the non-Hodgkins aren't. It's T1114, fuses cyclin D1 gene next to the immunoglobulin heavy chain gene locus. So it's like SLL. You get kind of a diffuse effacement of the architecture, but you don't see proliferation centers, whereas you do see those in SLL. And it can commonly involve the GI tract, what's called lymphomatoid polyposis. So it looks like basically polyps, and those polyps are microscopically just have tons of the neoplastic lymphoid cells. You see surface IgM and IgD, CD20 because it's B cell, and then once again CD5. So CLL, SLL, and mantle cell are the ones that are B cell neoplasms that have a T cell marker, CD5. That's why I think that one's great to know, because it really stands out. So mantle cell lymphoma, this is just what it looks like. I think identifying these would be tricky. I looked at the picture in Robbins where it says there's proliferation centers. In my eye, there's no arrow showing where it is, and it's, I don't know. So I think these can be really difficult. Hematopathologists have a really good eye and stuff. So I think they'll give you plenty of information to come to your diagnosis and not necessarily expect you to identify this one or some of them only on the microscopic would be my thought. So it says they often have generalized disease at presentation. They can involve bone marrow, as I showed you in the first lecture. Spleen, liver, if it involves those, you get more cells inside of it. Anytime you have more cells inside of it, you could have enlargement of it. And it's moderately aggressive and incurable. So this is the way it was explained to me. And this is always changing, it seems like, with the development of new treatments. But the red line is like a diffuse large B-cell lymphoma. It's a very aggressive neoplasm, but because it's dividing, the cells can be targeted and killed. So basically people die quickly at first, but if they survive, then they usually survive for a long period of time. Whereas the blue is follicular lymphoma. So they live for quite some time with follicular lymphoma, but it's not curable. And mantle cell is kind of the worst of both. People die relatively quickly, but there is no cure for it. So these are just this is not meant to be an accurate representation of the things, but just more of a generalization to say understand kind of what happens with them and the survival in that. Okay, so when I was flying back from Texas in winter, there's actually, this isn't it, but because I got to find it, but south of Billings, there's Bighorn Canyon. It's like a mini Grand Canyon. It's kind of interesting. I've seen it one time from the air. I haven't actually been down there on the ground, but there's actually some really neat mountains and stuff around here. So even though I grew up in northwest corner of Libby, northwest corner of Montana in Libby, it's very mountainous. It's kind of interesting living around Billings and stuff. There's some neat mountains. So extranodal marginal zone lymphoma or maltoma. This is from the memory B cells. And so it arises in association with inflammation. So the places you would expect to see inflammation be the stomach with chronic gastritis, salivary glands with things like Sjogren's, thyroid gland, things like Hashimoto's, intestine, lung with various types of chronic inflammatory process orbit. So these are all sites of chronic inflammation. So when you have a disease process that can cause chronic inflammation, that could potentially give rise to an extranodal, outside the lymph node, marginal zone lymphoma. And the translocations 11, 18. What you see are collections of small clusters in the epithelial tissue, so what they call a lymphoepithelial lesion. And because they're from the memory B cell, they can potentially have plasma cell differentiation. So you'd expect their CD20, their B cells, and then immunoglobulin M on the surface. And as has been said, important point, I think the bigger thing is they arise in the background inflammation. So I remember we were told that usually what happens in the past, if people developed a lymphoma of the stomach, they had a resection. This is quite some time ago. But then they realized that what was causing it was H. pylori and the inflammation associated with it. And they determined that if they treated the H. pylori, they could actually reverse the neoplasm. This is like one neoplasm that can actually be reversed by treatment. Usually when things become clonal, they're on their own, and it obviously is a clonal population, but it can be reversed by getting rid of the inflammation. So there's a poem talking about that, about how people used to have a gastrectomy and now it's treated with Pepto-Bismol and antibiotics. So diffuse large B-cell lymphoma, so I've mentioned this one. This one also comes from the germinal center or post-germinal center B cells. Adults, so older adults, that says that they can, and a lot of these could potentially occur. I remember when I was talking about bone tumors and stuff like that, that one of the students I taught one time said their family had a adult with Ewing sarcoma. So usually Ewing sarcoma is found in adolescents, kids, but so you can see these. There's not absolute usually, but they're usually adults. They're usually a rapidly enlarging mass. They're a more aggressive acute lymphoma, and it oftentimes can be extranodal. But it presents more as a mass, so not really diffuse. So I think you could look at it as like with diffuse disease, it's more of a indolent process, so it kind of can grow up before it's identified, whereas when it's rapidly growing, it's more likely to grow in that one spot and present. That's kind of my way of thinking about it. So they kind of see a rearrangements of BCL6, or point mutations in the BCL6 promoter. It says it's very heterogeneous, though. You can see some other ones too, but there's not really like one classic one. Like the other ones I've been telling you, there's usually one classic one and some other less or so. But diffuse large B cell, it says there's quite a few. It's kind of just that can be possible. They're very large cells, as the name implies, and they can have a very variable appearance, but they have prominent nucleoli, so they can almost look like Hodgkins. They're B cells, so 19 and 20. And CD10 more mature, and then they're closer toward the end, so surface IgM or IgG. So here's diffuse large B cells. So you can see they're large cells. They're not small lymphocytes. They have prominent nucleoli, and they basically have obliterated the tissue type. There are some specific subtypes of it. You can have an EBV-associated diffuse large B cell lymphoma, usually found in patients who have AIDS or other forms of immunosuppression. Primary effusion lymphoma, so this affects the cavities, so pleural, peritoneal, or pericardial, and it's associated with HHV8, with the Kaposi sarcoma virus. And then mediastinal large B-cell lymphoma usually affects younger females, so this would be one that would stand out because normally diffuse large B-cell is found in an older population. This is one that affects somewhat younger females. So we've been talking about a lot of lymphomas that affect adults. Burkitt's would be one that affects kids. So Burkitt's has two basic types. It's endemic in Africa, which it usually affects the jaw, and sporadic is elsewhere. And a common location for that is GI tract. So this is one that's associated with the MYC, and usually MYC is put next to the immunoglobulin heavy chain gene locus, so 814. But it can also be put next to the light chain loci as well, too. So that's kind of the way I remember those translocations. There's just that 14 and the immunoglobulin heavy chain and the fact that it's going to be red all the time, and so then the translocation it puts next to it. Characteristically, this one I can see them asking you to identify. It has a starry sky pattern. That starry sky pattern is produced because this is an aggressive neoplasm, so the cells are turning over, and so macrophages are engulfing apoptotic cells, dead cells, things like that. And so you'll see these macrophages scattered out, and that's what creates the starry sky pattern. It's a B cell, so CD20, later, so CD10. They could also have BCL6. And then if the endemic cases, the jaw, they're essentially always associate EBV, and the sporadic cases are associated EBV in a large number of them. So, and of course, it would not express BCL2, because if it expressed BCL2, it wouldn't. That's where they're anti-apoptotic, whereas this one has a more aggressive dividing neoplasm. So here's the starry sky pattern. Top left is like a low power, bottom right is a higher power. You can see the macrophages there. I put the key things, so it's the main translocation is 814. It's the MYC gene on 8. But I can see them asking you this and expecting you to know this pattern, because it is fairly characteristic, this starry sky pattern in Burkitt lymphoma. Remember, it's an aggressive neoplasm, so it means it's rapidly growing. Commonly presents at extranodal sites, whereas most other ones present in the lymph nodes, and it can actually present as leukemia. So remember that crossover between leukemia and lymphoma. It's not black and white between the two. Obviously, what's in the blood can get in the lymph nodes, and what's in the lymph nodes can get in the blood. Okay, so pause, answer the question, and then we'll go on. So this one's just asking what is it's telling you the diagnosis. And like I said, I would hope they wouldn't ask you to identify the mantle cell necessarily from the images. Like Burkitt's is really characteristic. Diffuse large B cell could be characteristic, but mantle cell, it seems like, is a little, I think, trickier. So the 1114 CD5 positive, cyclin D1. And remember that CD5 positivity is great because it's normally T cells, whereas these are B cells. So I think that stands out. So there's the answer. Second question. So it's giving you the diagnosis of extranodal marginal zone lymphoma. So it's a maltoma. So that's chronic inflammation. Okay, so found in areas of chronic inflammation. So enlarged lymph node, the person could have Sjogren's syndrome. There's the explanation. Last question. So it's giving you a diagnosis of Burkitt's. So Burkitt's is a B cell, so CD20, it's 814, and you see the MYC. So, okay, so once again, just use reflection. Go back, pause it, go back through it, and ask yourself, what are 5 important things I learned from this? It's a really good way to cement the material. I hope there were 5 important things you learned from it. And that. So, and then this is Billings from the air. There's the Yellowstone River. I could actually point out where I work, maybe, possibly. And then I live way on the western side of town. Anyway, I hope this lecture has been useful in your understanding of neoplastic disorders of the white blood cells, and thank you.